Spinal cord. The spinal cord is the lower elongated part of the central nervous system, CNS. It is cylindrical in shape, slightly flattened anteroposteriorly and occupies the upper two-thirds of the vertebral canal. Spinal cord measures about 45 cm, 18, in adult male and 42 cm in adult female, and weighs about 30 grams. It extends as a downward continuation of medulla oblongata from the upper border of the posterior arch of first cervical vertebra, C1, to the lower border of the first lumbar vertebra, Li. Its lower tapering extremity is called conus medullaris. The apex of conus medullaris continues downwards as a thin, thread-like filament called filum terminale. Spinal cord provides attachment to 31 pairs of spinal nerves which connect it to the tissues of the trunk, girdles, limbs, and the viscerae. The spinal cord contains large number of ascending and descending pathways, which serve as conduits for nervous information, passing to and fro between different parts of the body and the brain. Functions of the spinal cord. The execution of simple reflexes. The transmission of impulses to and from the brain. Positional changes of the cord. Up to the third month of intrauterine development, the spinal cord extends throughout the entire length of the vertebral canal and the spinal nerves pass through the intervertebral foramina at their level of origin. Thereafter, the vertebral column grows faster than the spinal cord and the terminal end of the spinal cord gradually shifts to a higher level. Consequently, at birth spinal cord ends at the level of third lumbar vertebra, while in adult, it terminates at the level of lower border of L1, 0R, the intervertebral disc between the Li and L2. The knowledge of these variations in the vertebral level of the lower end of the cord is important to avoid injury to the cord while performing lumbar puncture, especially in children. Spinal meninges. The spinal cord is surrounded by three protective membranes called spinal meninges. From outside inward, these are dura mater, arachnoid mater, and pia mater, Figs 7.1 and 7.2. Dura mater. The spinal dura extends from foramen magnum to the lower border of second sacral vertebra, S2. The space between spinal dura and vertebral canal is termed epidural space. This space contains loose areolar tissue, semiliquid fat and internal vertebral venous plexus. The space between dura and arachnoid mater termed subdural space. It contains capillary layer of fluid. The spinal dura differs from cranial dura. The differences between the two are enumerated in Table 7.1. Table 7.1 Differences between spinal and cranial dura. Arachnoid mater is a thin, delicate, transparent avascular membrane which invests the spinal cord loosely. Above it is continuous with the arachnoid mater of the brain, and below it extends up to the lower border of the second sacral vertebra, S2. Pia mater is a thin, highly vascular membrane that closely invests the spinal cord and continues below the spinal cord as a thin thread-like prolongation, the filum terminale. The subarachnoid space between the pia mater and the arachnoid mater is filled with cerebrospinal fluid, CSF. Above it is continuous with subarachnoid space around the brain. Distal to the termination of spinal cord, the subarachnoid space around the filum terminale becomes roomy, forming a pool of CSF called lumbar cistern. The lumbar puncture is done at this site to take out the CSF, Fig. 7.3. Clinical correlation. Lumbar puncture is done to withdraw cerebrospinal fluid for various diagnostic and therapeutic purposes. The puncture should be done well below the termination of the cord, i.e. lower border of Li. A horizontal line joining the highest points of the iliac crests passes through the spine of the fourth lumbar vertebra. Therefore, the interspinous spaces immediately above and below this landmark can be used with safety. The interspinous space between L3 and L4 is the most preferred site, Fig. 7.3. Because in this region subarachnoid space is more roomy and contains only filum terminale and roots of lumbar, sacral and coccygeal nerves forming the cauda equina. During this procedure, the spine must be fully flexed with patient either lying on the side or seated, so that the interspinous spaces are opened up to their maximum extent and lower end of spinal cord is slightly raised. The needle is passed inwards and somewhat cranially exactly in the midline. The supraspinous and interspinous ligaments are traversed, and then dura mater is penetrated, the latter with distinct feel of give way. Occasionally, the root pain is experienced if the roots of cauda equina are impinged upon, but usually, they float clear of the needle. Processes of the pia mater, also called special parts of the pia mater. 1. Filum terminale. It is a delicate, glistening white thread-like structure extending from tip of conus medullaris to the first coccygeal vertebra, dorsal aspect. The filum terminale is about 20 cm long and mainly composed of non-nervous fibrous tissue, pia, but few nerve fibers, considered to be the rudiments of second, third and fourth coccygeal nerves, are found embedded in its upper part. The central canal of spinal cord extends into the upper part of the filum terminale for about 5 mm. The filum terminale consists of two parts, a, filum terminale internum, and b, filum terminale externum. The filum terminale internum is about 15 cm in length and lies within the dural sac. The filum terminale externum is about 5 cm in length and lies outside the dural sac, i.e., below the level of second sacral vertebra, Fig. 7.3. 2. Subarachnoid septum. It is a mid-sagittal fenestrated peel septum which connects the dorsal surface of the spinal cord with the arachnoid mater. 3. Linea splendens. The pia gives off a septum into the anterior median fissure. Where this process is given off, the pia mater presents a thickening, called linea splendens. 4. Ligamenta denticulator. These are two transparent ribbon-like thickened bands of pia mater, one on each side, extending laterally between posterior and anterior nerve roots from pia mater covering the cord. The lateral margin of each band presents 21 tooth-like processes which pierce the arachnoid, to be attached to the inner surface of the dura mater between the points of emergence of the spinal nerves, Fig. 7.4. The ligamenta denticulator help to anchor the spinal cord in the middle of subarachnoid space. The first teeth of ligamentum denticulatum lies at the level of foramen magnum while the last between T12 and Lee spinal nerves. Clinical correlation. The ligamenta denticulator serve as a guide to neurosurgeons during cordotomy operation. When sensory tract requires section to relieve pain, the knife is put in front of the ligament, and if the section of motor tract, viz. pyramidal tract, is desired, the knife is placed behind the ligament. The lowest tooth is forked, and the posterior root of the first lumbar nerve lies on the outer prong of the fork, Fig. 7.5. In the lower region of the spinal cord, it is the surgeon's guide to the first lumbar nerve and gives him a nerve root of known number from which he can determine the position of whatever nerve roots he is in search of. External features of the spinal cord. The external features of the spinal cord are Fig. 7.6. 1. Fissures and sulci. 2. Attachment of spinal nerves. 3. Enlargements. 4. Cauda equina. Fissures and sulci. The anterior aspect of the spinal cord, Fig. 7.6a, presents anterior median fissure, and 2 anterolateral sulci while the posterior aspect, Fig. 7.6b, presents posteromedian sulcus, 2 posterolateral and 2 posterointermediate sulci. The anterior median fissure is deep and extends along the entire length of the cord. The anteriospinal artery runs in it. The posterior median sulcus is a faint longitudinal groove. From its floor, a septum of neurally tissue, posterior median septum, extends into the substance of the cord to a variable extent. The surface of the cord is divided into 2 symmetrical halves by an anterior median fissure and a posterior median sulcus. Each half of the cord is 30 subdivided into posterior, lateral and anterior regions by anterolateral and posterolateral sulci. Through anterolateral sulcus emerge the ventral root fibers and through posterolateral sulcus enter the dorsal root fibers of the spinal nerves. Attachment of spinal nerves. 31 pairs of spinal nerves emerge from the sides of the cord. Of these, 8 are cervical, 12 are thoracic, 5 are lumbar, 5 are sacral, and 1 is coccygeal. The cervical nerves leave the vertebral canal above the corresponding vertebrae with the exception of 8th, which emerges between 7th cervical and 1st thoracic vertebrae. The remainder spinal nerves emerge below the corresponding vertebrae. Each spinal nerve is attached to the cord by 2 roots, anterior motor root and posterior sensory root. The posterior root has a ganglion, the posterior root ganglion consisting of pseudonipolar cells. Each of the 2 roots is made up of number of rootlets that arise from the spinal cord over a certain length, Fig. 7.7. The rootlets of posterior root enter the dorsolateral aspect of the cord along the posterolateral sulcus, whereas the rootlets of anterior root emerge from the anterolateral sulcus, anterolateral aspect of cord opposite to the anterior gray column. Spinal segments. Like the vertebral column, the spinal cord is also segmented, though the segments are not visible externally. The part of spinal cord to which a pair of spinal nerves, right and left, is attached is known as spinal segment, Fig. 7.8. The number of spinal segments corresponds to the number of vertebrae in thoracic, lumbar and sacral regions, but in cervical region, one segment is more than the number of vertebrae, whereas in coccygeal region there is only one segment for 4 coccygeal vertebrae. Thus, the spinal cord is made up of 31 spinal segments, 8 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 1 coccygeal. Since the length of spinal cord, 45 cm, is smaller than the length of vertebral column, 65 cm, the spinal segments are short and crowded, especially in the lower part of the cord. Thus, the spinal and vertebral segments spines do not lie at the same level. The spinal segments as a rule always lie above their numerically corresponding vertebral spines. In the lower part of the spinal cord, they lie well above their corresponding vertebrae, Fig. 7.9. For example, the lumbar segments are related to the thoracic vertebrae. Approximate vertebral levels matched to spinal cord segments. Table 7.2. Table 7.2 Approximate vertebral levels of the spinal cord segments. These levels, although not strictly accurate, give a reliable assessment of the level of cord compression following an injury or disease of the surrounding vertebrae. The approximate relationship helps in understanding the consequences of spinal injuries and clinical findings of motor and sensory levels. They also help in planning for surgical approach for diagnostic and therapeutic purposes. Enlargements. The spinal cord is roughly cylindrical in shape with an average diameter of about 1.25 centimeters. However, opposite to the attachments of the nerve roots contributing to the formation of brachial and lumbosacral plexuses, the spinal cord presents definite fusiform swellings called cervical and lumbar enlargements respectively, Fig. 7.6a, b. These enlargements are produced due to the presence of large number of large motor neurons in these regions to supply the musculature of the upper and lower limbs and associated girdles. The cervical enlargement extends from C5 to T1 spinal segments, whereas lumbar enlargement extends from L2 to S3 spinal segments. The vertebral levels of these enlargements are quite different from those of spinal segments, viz. The cervical enlargement lies opposite C3 to T1 vertebrae and lumbar enlargement lies opposite T9 to L1 vertebra. The two enlargements are compared in Table 7.3. Table 7.3 Comparison between cervical and lumbar spinal enlargements. Cauda equina. Since the cord is shorter than the vertebral column, length and obliquity of spinal nerve roots increase progressively from above downwards, so that spinal nerves may emerge through their respective intervertebral foramina, Fig. 7.10a. As a result, the nerve roots of lumbar, sacral and coccygeal nerves from the caudal part of the cord takes more or less a vertical course and form a bunch of nerve fibers around the filum terminale called cauda equina because of its fancied resemblance to the tail of a horse, cauda, tail, equina, horse. The cauda equina consists of the roots of the lower 4 pairs of lumbar, 5 pairs of sacral and 1 pair of coccygeal nerves, Fig. 7.10b. Internal nerves from the caudal part of the cord takes more or less a vertical course and form a bunch of nerve fibers around the filum terminale called cauda equina because of its fancied resemblance to the tail of a horse, cauda, tail, equina, horse. The cauda equina consists of the roots of the lower 4 pairs of lumbar, 5 pairs of sacral and 1 pair of coccygeal nerves, Fig. 7.10b. Internal structure of the spinal cord. The cross-section of the spinal cord, Fig. 7.11, shows that it consists of an inner core of gray matter, and a peripheral zone of white matter. Gray matter. In cross-section of cord, the gray matter is seen as H-shaped, or butterfly-shaped, fluted column, extending throughout the length of the spinal cord. It is divided into symmetrical right and left comma-shaped masses which are connected across the midline by a transverse gray commissure. The central canal of the cord passes through the center of gray commissure. The canal is surrounded by substantia gelatinosa centralis. The lateral comma-shaped mass of gray matter is further divided by a transverse gray commissure into a narrow elongated posterior horn, and a broad anterior horn. In the thoracic region and upper two lumbar segments, T1 to L2, a triangular projection juts from the side of lateral gray mass between the anterior and posterior horns, nearly opposite to the gray commissure. It is called lateral horn. The posterior horns are connected to the surface by a gelatinous substance called substantia gelatinosa. The amount of gray matter and shapes of its horns, and amount of white matter varies at different levels, Fig. 7.12. The amount of the gray matter seen at a particular level is well correlated with the mass of tissue it supplies. It is, therefore, maximum in the regions of cervical and lumbar enlargements, which supply the limbs and their associated girdles. The horns are thus largest in the regions cervical and lumbar enlargements. The amount of white matter in the spinal cord undergoes progressive increase from below upwards. This occurs due to following facts. 1. Progressively more and more ascending fibers are added to the cord from below upwards. 2. Number of descending fibers decreases in the cord from above downwards as some of them terminate in each spinal segment. For this reason, the amount of white matter is massive in the cervical segments and very less in the sacral segments. Table 7.4 reveals the characteristic features of the spinal segments in different regions of the spinal cord. Table 7.4. Structure of the gray matter. Like in other regions of the CNs, the gray matter of spinal cord consists of a. Nerve cells, b. Neuroglia, and c. Blood vessels. Neurons in the gray matter of the spinal cord. The nerve cells in the gray matter of spinal cord are multipolar and can be classified into the following two ways. Structural classification. Golgi type 1, having long axons, which leave the gray matter and either join the anterior nerve roots or form the nerve tract. Golgi type E, having short axons, which do not leave the gray matter and remain intrasegmental or intersegmental in position. Functional classification. Motor neurons, these are present in the anterior and lateral horns. Types of motor neurons in the anterior gray columns. 1. Alpha neurons. They are large multipolar cells, 25 or more in diameter, and supply the extrafusal skeletal muscle fibers. 2. Gamma Y neurons. They are small multipolar cells, 15 to 25 in diameter, and supply the interafusal muscle fibers of the neuromuscular spindles in skeletal muscles. N. B. The axons of motor neurons leave the spinal cord as the final common path, Sherrington, through the ventral roots of the spinal nerves and reach the skeletal muscles. Sensory neurons, these are present in the posterior horn and involved in relay of sensory information to the different parts of the brain, forming ascending tracts, or to the other segments of spinal cord forming intersegmental tract. Interneurons, these are small neurons present out the gray matter of the spinal cord. They connect different types of neurons, hence also called association neurons. These are either inhibitory or excitatory, and concerned with integration of segmental activities. Nerve cell groups in the gray columns of the spinal cord, Fig. 7.13. Cell groups in the anterior gray column. Numerous groups of motor neurons are found in the cross-section of anterior gray column, representing several longitudinally arranged columns of varying length. They are divided into three main groups or nuclei, A. Medial, B. Lateral, and C. Central. Medial group extends along most of the length of the spinal cord and innervate the axial musculature of the neck and trunk. This is are subdivided into ventromedial and dorsomedial parts. Lateral group confines in the cervical and lumbosacral enlargements and supply the limb muscles. Central group forms three definite nuclei which are fairly localized. These are as follows: phrenic nucleus, in the cervical region, extending from C3 to C5 segments, and innervating the diaphragm. Lumbosacral nucleus in the lumbosacral region, extending from L2 to S3 segments. Its function is unknown so far. Spinal nucleus of accessory, cranial, nerve in the cervical region, extending from C1 to C5 segments, and giving origin to spinal root of accessory. Cell groups in the posterior gray column. In the posterior gray column, the cell groups are arranged into four longitudinal columns. From the apex towards the base, they are A. Substantia gelatinosa, of Rolandi, B. Nucleus proprius, C. Nucleus dorsalis, or Clark's column, and D. Visceral afferent nucleus. Substantia gelatinosa is situated at the apex of the posterior gray column and extended through the length of spinal cord. It is composed of small Golgi type E neurons, also called interneurons. It receives the afferent fibers of the lateral division of the posterior nerve roots, conveying primarily the pain and temperature sensations. Some of these fibers synapse with the interneurons of substantia gelatinosa. The substantia gelatinosa is continuous above with the nucleus of spinal tract of the trigeminal nerve. Nucleus proprius is a group of large nerve cells situated anterior to the substantia gelatinosa and constitutes the main bulk of cells present in the posterior gray column. It extends along the whole length of the spinal cord and receives the fibers from posterior white column that are associated with the sense of position and movement, proprioception, TW0 point discrimination, and vibration. Nucleus dorsalis, Clark's column, occupies the medial part of the base of the posterior gray column, projecting somewhat into the posterior funiculus, and extends from C8 to L2 per liter 3 segments of the cord and receives proprioceptive afferents, muscle and joint sense, and exteroceptive afferents, touch and pressure, from the trunk and lower limb. Visceral afferent nucleus is located lateral to the nucleus dorsalis and extends from T1 to L2 and from S2 to S4 segments of the cord, and receives visceral afferent from dorsal nerve roots. Cell groups in the intermediate, lateral, gray column. The cells of the lateral gray column form two nuclei, A. Intermediolateral, and B. Intermediomedial. Intermediolateral nucleus extends from T1 to L2 segments of the cord and gives origin to preganglionic fibers of the sympathetic nervous system, thoracolumbar outflow, which leave the cord along with anterior nerve roots. Intermediomedial nucleus extends from S2 to S4 segments of the cord and gives origin to preganglionic fibers of parasympathetic nervous system, sacral outflow, which also pass out through the anterior nerve roots of the corresponding sacral nerves. The summary of the characteristics of the various cell columns in the spinal cord is presented in the Table 7.5. Table 7.5 Summary of the various cell columns, nuclei in different horns, gray columns, of the spinal cord. NB. Apart from the central gray matter, there are strands of gray matter in the lateral white column adjacent to the base of the posterior horn, which are termed reticular formation. Laminar architecture of gray matter, Rext laminae, Fig. 7.14. The cytoarchitecture of gray matter of spinal cord is alternatively divided into 10 zones or laminae by Rext, Table 7.6. These are numbered consecutively by Roman numerals, starting at the tip of the posterior horn and moving ventrally into the anterior horn. Table 7.6 Rext laminae and nuclear groups. This concept of laminae is useful in experimental works only and provides information about the localization of terminal degenerating fibers after section of posterior nerve roots or descending nerve tracts. White matter. The white matter of the spinal cord surrounds the central H-shaped mass of gray matter, and mainly consists of nerve fibers, the large proportion of them being myelinated, give it a white appearance. Types of fibers in the white matter. Functionally, the fibers in the white matter of spinal cord are divided into following three types. 1. Sensory fibers. These include the central processes of primary sensory neurons of the posterior root ganglia which enter the spinal cord and ascend or descend for varying lengths, and the ascending fibers from the nuclei of spinal gray columns that convey sensory modalities to the higher centers. 2. Motor fibers. These include the descending fibers from higher centers, supraspinal levels, to the spinal cord, and the nerve fibers of anterior and lateral horn cells that go to the motor roots of the spinal nerves. 3. Association fibers. These fibers originate and end within the spinal cord, interconnecting the neurons of the same segment or of different segmental levels. Divisions of white matter. In each half of the spinal cord, the white matter is divided into three parts called white columns or funiculi, Fig. 7.11. Posterior white column, between the posterior median septum and the posterior horn. Lateral white column, between the anterior and posterior horns. Anterior white column, between the anterior median fissure and the anterior horn. The anterior white columns are joined together by the white commissure. Each white column is made up of tracts which are either ascending, sensory, descending, motor, or intersegmental, association. NB. In general, the posterior white column is sensory, the anterior column is motor and lateral column is mixed, i.e. motor as well as sensory. Further, the ascending tracts are located at the periphery and the descending tracts in the center. Tracts of the spinal cord. The tracts are defined as collections of nerve fibers within the central nervous system, which have same origin, course and termination. They are sometimes referred to as fasciculi, equals bundles, or lemnici, ribbons. The tracts are named after the names of masses of gray matter connected by them, Fig. 7.16. The usually consists of two components, or terms. The first term denotes the origin and second the termination of the tract. For example, a tract arising in cerebral cortex and terminating in the spinal cord is called corticospinal tract. Similarly, a tract arising in the spinal cord and terminating in the thalamus is called spinothalamic tract. Classification of the tracts. The tracts are classified into three types: A. Descending, B. Ascending, and C. Intersegmental. Table 7.7. Table 7.7 Classification of the tracts of the spinal cord. The distribution of different descending and ascending tracts in three white columns, anterior, lateral, and posterior, of the spinal cord are summarized in Table 7.8. Table 7.8. Descending tracts. The descending tracts conduct the impulses to the spinal cord from the brain. The location, origin, termination and function of the major tracts are summarized in Table 7.9. Table 7.9 Major descending tracts in the spinal cord. Some of these tracts are discussed below in brief. Corticospinal tract, pyramidal tract, Fig. 7.17. The pyramidal tract consists of about 1 million fibers. The pyramidal tract is so named because corticospinal tract traverses the medullary pyramids, but it also includes corticobulbar, corticonuclear fibers which descend to brainstem, across to the opposite side and terminate by synosing with nerve cells of brainstem nuclei of the cranial nerves. Origin. The most of the fibers of corticospinal tracts arise from pyramidal cells, of beds, of the motor area of the cerebral cortex. Some fibers arise from other parts of the cortex. Course. The fibers pass through corona radiata, internal capsule, crus cerebri of cerebral peduncles, ventral part of the pons and pyramids of the medulla oblongata. In the lower part of the medulla, majority of fibers, about 75%, cross to the opposite side at the pyramidal decussation of the medulla and descend in the lateral white column of the spinal cord as the lateral corticospinal tract. The uncrossed fibers descend in the anterior white column of the spinal cord as the anterior corticospinal tract. The lateral corticospinal part also contains some fibers which arise from the ipsilateral cerebral cortex. The lateral corticospinal tract lies in the lateral white column in front of the posterior horn and medial to the posterior spinocerebellar tract. The anterior corticospinal tract lies in the anterior white column close to the anterior median fissure. Lower down, the fibers of anterior corticospinal tract also cross to the opposite side in the anterior white commissure of the spinal cord at the level of their termination. Termination. The most of the fibers of both lateral and anterior corticospinal tracts terminate by synapsing with the interneurons, which in turn project to the motor neurons, or NY, of the anterior horn. Only 2% of the fibers synapse directly with the motor neurons. NB. Because of decussation of corticospinal fibers in the medulla, medullary decussation, the cerebral cortex of one side controls the muscles of the opposite half of the body. Clinical correlation. The lesions of pyramidal tract above the level of decussation, i.e. upper motor neuron, UMN, lesions, result in the loss of voluntary movements in the opposite half of the body below the level of the lesion. The muscles are not actually paralyzed, but the control of upper motor neurons and the lower motor neurons, LMN, supplying muscles is lost. As a result, LMNs become hyperactive and the tone of muscles is increased, leading to spastic paralysis. The fibers of this tract arise from the cells of red nucleus, nucleus ruber, located in the midbrain and immediately caudal to red nucleus. They decussate with those of the opposite side and descend as a compact bundle in the lateral white column of the spinal cord, ventral to the lateral corticospinal tract. The fibers of this tract end just like those of corticospinal tract in the anterior horn cells of the spinal cord. This tract forms a part of extrapyramidal system. Rubrospinal tract facilitates the activity of the flexor muscles and inhibits the activity of the extensor or anti-gravity muscles. Reticulospinal tracts. Lateral reticulospinal tract lies in the lateral white column. Its fibers arise from cells of the reticular formation in the brainstem, midbrain, pons and medulla, and relay in the anterior horn cells. This tract exerts facilitatory influence on the motor neurons, which supply the skeletal muscles. Medial reticulospinal tract lies in the anterior white column. Its fibers arise from the cells of the reticular formation in the medulla and relay in the anterior horn cells of the spinal cord. This tract exerts inhibitory influence on the motor neurons supplying the skeletal muscles. NB. The reticulospinal fibers are now thought to include the descending autonomic fibers. The reticulospinal tracts thus provide a pathway by which the hypothalamus can control the thoracolumbar sympathetic outflow and the sacral parasympathetic outflow. Hypothalamo-spinal tract projects from the hypothalamus, descends in the lateral white column of spinal cord on the medial side of the lateral corticospinal tract, and terminates by synapsing with lateral horn cells of TL to L2 spinal segments responsible for sympathetic outflow, and lateral horn cells of S2, S3, and S4 spinal segments responsible for parasympathetic outflow. Ascending tracts. The important ascending tracts fall into the following three types. 1. Those concerned with pain and temperature sensations and crude touch, e.g. lateral and anterior spinothalamic tract. 2. Those concerned with fine touch and conscious proprioceptive sensations, e.g. fasciculus gratulus and fasciculus cuneatus. 3. Those concerned with unconscious proprioception and muscular coordination, e.g. anterior and posterior spinocerebellar tract. Lateral spinothalamic tract, Fig. 7.18. The cell bodies of first-order sensory neurons, pseudounipolar neurons, of this tract lie in the dorsal root ganglia of the spinal nerves. The central processes of these cells enter the cord through the lateral division of the dorsal root of the spinal nerves. In the cord the fibers ascend one or two segments in the dorsolateral tract of Lissauer at the tip of posterior horns and then relay in the posterior horn by synapsing with the cells of substantia gelatinosa. The axons of second-order sensory neurons of substantia gelatinosa cross to the opposite side in the anterior white commissure and ascend up as lateral spinothalamic tract in the opposite lateral white column just lateral to the anterior horn. They terminate in the ventral posterolateral nucleus, VPL, of the thalamus. The sacral, lumbar, thoracic and cervical fibers are situated in layers in this tract from superficial to deep, somatotrophic organization. The axons of the third-order sensory neurons project to the primary sensory cortex of the cerebral hemisphere. Clinical correlation. The fibers of this tract carry pain and temperature sensations, the pain fibers being lateral to the temperature. The pain fibers become very superficial in the lateral white column of the cord in the cervical region. Therefore, cordotomy can be performed safely at this level to relieve pain in the opposite half of the body. The involvement of decusseting fibers of this tract in the anterior commissure in syringomyelia leads to bilateral loss of pain and temperature sensations below the level of the lesion. Anterior spinothalamic tract. The anterior, or ventral, spinothalamic tract carries light touch, pressure, tickle, and itch sensations from the opposite half of the body. The cell bodies of the first-order sensory neurons of this tract lie in the dorsal root ganglia of the spinal nerves. The central process of these cells, large and heavily myelinated, enter the cord through the medial division of the dorsal roots of the spinal nerves and ascends in the cord one or two segments in the dorsolateral tract of Lissauer and relay in the substantia gelatinosa of the posterior horn. The axons of second-order sensory neurons of substantia gelatinosa cross the midline in the anterior white commissure and then ascend as ventral spinothalamic tract in the opposite rear white column just in front of the anterior horn. These fibers terminate in the ventral posterolateral nucleus of the thalamus, Fig. 7.18. NB. The lateral spinothalamic tract carries pain and temperature sensations, whereas anterior spinothalamic tract carries sensations of crude touch and pressure. Clinical correlation. The damage of anterior spinothalamic tract leads to loss of light touch and pressure on the opposite of the body below the level of the lesion. Fasciculus gratulus, tract of Goll, and fasciculus cuneatus, tract of Burdick. These two tracts occupy the posterior white column of the cord, the fasciculus gratulus being medial to the fasciculus cuneatus. They carry sensations of conscious proprioception, two-point tactile discrimination and vibration. The cell bodies of the first-order sensory neurons lie in the dorsal root ganglia of the spinal nerves. The central processes of these cells, thickly myelinated, enter the cord through the medial division of the roots of spinal nerves and continue in the posterior white column as fasciculus gratulus and fasciculus cuneatus, Fig. 7.19. Fibers from the coccygeal, sacral, lumbar, and lower thoracic segments ascend up in the fasciculus gratulus, while the fibers from the upper thoracic and cervical segments run in the fasciculus cuneatus. The cervical, thoracic, lumbar, and sacral fibers are arranged in that order from lateral to medial in these tracts. The fibers of fasciculus gratulus and fasciculus cuneatus terminate in nucleus gratulus and nucleus cuneatus respectively. The axons of second-order sensory neurons from nucleus gratularis and nucleus cuneatus curve ventromedially around the central gray matter of the medulla as internal arcuate fibers to undergo decussation. The fibers after crossing the midline turn upwards as a flat tract called medial lemniscus, which courses upwards to terminate in the ventral posterolateral nucleus (VPL) nucleus of the thalamus. The third-order sensory neurons from thalamus project into the cerebral cortex of the cerebral hemisphere. This pathway carrying conscious proprioceptive sensations is termed dorsal column medial lemniscus pathway. Clinical correlation. The involvement of posterior white columns and posterior nerve roots in syphilitic degenerative disease called tabes dorsalis leads to loss of sense of position. The patient is not able to tell the position or movements of his lower limbs unless he sees them. Therefore, when he is asked to stand up with his feet together and eyes closed, he staggers and falls because he cannot maintain his correct position due to lack of proprioceptive information, Romberg's sign. Spinocerebellar tracts, Fig. 7.20. The spinocerebellar fibers are located in the lateral white column of the cord and are divided into two tracts, posterior spinocerebellar tract and anterior spinocerebellar tract according to their location in the cord. They carry unconscious proprioceptive sensations from cord to the cerebellum and play an important role in muscular coordination. Posterior, dorsal, spinocerebellar tract. The cell bodies of the first-order sensory neurons lie in the dorsal root ganglia of the spinal nerves. The central processes of these cells enter the posterior horn of the gray matter through posterior roots of spinal nerves and relay in the nucleus dorsalis, Clark's column. The axons from cells of nucleus dorsalis, second-order sensory neurons, pass to the dorsolateral part of the white column on the same side and ascend as posterior spinocerebellar tract. The fibers of the tract enter the cerebellum through the inferior cerebellar peduncle and terminate in the ipsilateral cerebellar cortex. Anterior, ventral, spinocerebellar tract. The origin and course of the first-order sensory neurons is same as that of posterior spinocerebellar tract. They axons of cells of nucleus dorsalis, second-order sensory neurons, cross to the opposite side and pass to the anterolateral part of the lateral white column of the spinal cord and then ascend to form the anterior spinocerebellar tract. The fibers of anterior spinocerebellar tract enter the cerebellum through superior cerebellar peduncle and terminate in the ipsilateral cerebellar cortex. The input of both posterior and anterior spinocerebellar tracts is ipsilateral. Functionally, both posterior and anterior spinocerebellar tracts carry impulses from the lower limb. The posterior tract is concerned with fine movements, whereas anterior tract is concerned with gross movements of the limb as a whole. To summarize, the motor impulses travel from the brain to the anterior horn cells of spinal cord through the descending tracts and then out to the periphery via the spinal nerves. The sensory impulses from the periphery travel through spinal nerves into the spinal cord via posterior or dorsal horn and then up the spinal cord to the brain through ascending tracts. The major descending and ascending tracts passing through the spinal cord and bridge ainstem are shown schematically in Figs 7.21a and 7.21b. They are described in detail in Chapter 17. The location, origin, termination and function of major ascending tracts are listed in Table 7.10. Table 7.10 Major ascending tracts in the spinal cord. Intersegmental tracts. The short ascending and descending tracts, which originate and end within the spinal cord, exist in the anterior, lateral and posterior white columns. The function of these tracts is to interconnect the neurons of different segmental levels. These tracts are particularly important in intersegmental spinal reflexes. Intrinsic spinal mechanisms. Spinal reflexes. The reflex may be defined as an automatic response to a stimulus that occurs without conscious thought. The major spinal reflexes include the withdrawal reflex, the stretch reflex, and the Golgi tendon reflex. Withdrawal reflex, also called flex or withdrawal reflex. This reflex is very important as it is directed toward the preservation of the animal. For example, if the sole of the foot of a sleeping person is pricked with a sharp pin, the leg is reflexly drawn up. The neural mechanism for this response is as follows. The action potentials, nerve impulses, produced by painful stimulus travel through the afferent neurons of the dorsal root of the spinal nerve to the spinal cord, where they synapse with the excitatory association neurons, which in turn synapse with the alpha motor neurons. The alpha motor neurons stimulate flexor muscles which remove the limb from the source of painful stimulus. The reflex arc involved in this reflex consists of 5 basic components, Fig. 7.22, and involves more than one synapse, hence, it is called polysynaptic reflex arc. Stretch reflex, see page 31. Golgi tendon reflex, see page 32. The classification of spinal reflexes is given in Table 7.11. Table 7.11. Classification of spinal reflexes. Reciprocal inhibition. The reciprocal inhibition is associated with the withdrawal reflex and increases the efficiency of this reflex. The collateral branches of afferent neurons that carry action potentials from pain receptors innervate inhibitory association neurons, which in turn synapse with and inhibit alpha motor neurons supplying extensor, antagonist muscles. Thus, when withdrawal reflex is initiated, the flexor muscles contract and extensor, antagonist muscles relax. Renshaw cell inhibition. The Renshaw cells are inhibitory interneurons in the anterior gray column. Some of alpha motor neurons give off collateral branches which make inhibitory synapses with the Renshaw cells. In turn, axons of Renshaw cells loop back to make synapses with the bodies of alpha motor neurons and prevent the excessive alpha firing. NB. Tetanus toxin suppresses the actions of Renshaw cells and produces convulsions. Clinical correlation. Syringomyelia, Fig. 7.23. In this condition, a fluid cavity, or cavities, develops near the center of the spinal cord, usually in the cervical segments, Fig. 7.23. This leads to the destruction of the cord involving central canal and its surrounding area. This lesion involves the decusseting spinothalamic fibers in the anterior white commissure, Fig. 7.23, so that there is bilateral loss of pain and temperature sensations below the lesion, but other sensations below the lesion, but other sensations are preserved in the uncrossed tracts of posterior columns. Thus, this condition results in what is called dissociated sensory loss. Hemisection. Effects of the hemisection of the spinal cord are as follows, Fig. 7.24. Ipsilateral upper motor neuron type of spastic paralysis below the level of hemisection, due to involvement of pyramidal tract. Ipsilateral loss of proprioceptive sensations, sense of position, posture, passive movement and vibrations, and fine touch, discrimination, due to involvement of posterior columns. Contralateral loss of pain and temperature sensations below the level of lesion, due to involvement of spinothalamic tract. NB. Touch is not completely lost because tactile impulses ascend on both sides of the cord. Tabes dorsalis. It is a syphilitic degenerative lesion of the posterior white columns and posterior nerve roots, Fig. 7.25. It is characterized by impairment of proprioceptive sensibility. The patient loses the sense of tactile discrimination, vibration, passive movement and appreciation of posture. The patient becomes ataxic, particularly if he closes his eyes, because he has lost his position sense, for which he can partially compensate by visual knowledge of his spatial relationship, Romberg's sign. Posterior rhizotomy or chordotomy. The intractable pain can be treated in selected cases by cutting the appropriate posterior nerve roots, posterior rhizotomy, or by division of the spinothalamic tract on the side opposite to the pain, chordotomy. A knife is passed 3 mm deep into the cord, anterior to the denticulate ligament, and then swept forward. It severs the lateral spinothalamic tract but preserves the pyramidal tract lying immediately behind it. Blood supply of the spinal cord. Arterial supply. The spinal cord is supplied by following arteries, Fig. 7.26a, b. 1. Anterior spinal artery. 2. 2 posterior spinal arteries. 3. Segmental arteries. The anterior spinal artery is formed by the union of 2 small spinal branches of the right and left vertebral arteries in the upper cervical canal. It runs caudally in the anterior median fissure of the spinal cord and terminates along the filum terminale. There are 2 posterior spinal arteries, Fig. 15.3, each arising as a small branch from either the vertebral or posterior inferior cerebellar artery. Each posterior spinal artery runs down on the posterolateral aspect of the cord in the posterolateral sulcus along the line of attachment of posterior nerve roots and usually divides into 2 collateral arteries along the medial and lateral sides of the posterior nerve roots. Thus, there are 5 longitudinal arteries around the spinal cord. These arteries are reinforced by the segmental arteries to form 5 longitudinal arterial trunks. These arterial trunks communicate around the cord, forming a peel plexus, the arterial vasocorona, arteriae coronae. The arteriae coronae give peripheral branches which supply the superficial regions of the cord, Fig. 7.27. The anterior spinal artery supplies the anterior 2/3 of the cord, while two posterior spinal arteries together supply the posterior 1/3 of the cord. Clinical correlation. Anterior spinal artery syndrome. It occurs due to occlusion, thrombosis or compression of the anterior spinal artery. Each segmental artery divides into anterior and posterior branch which enter the vertebral canal along the anterior and posterior nerve roots of corresponding spinal nerve, hence termed anterior and posterior radicular arteries respectively. Many of these radicular arteries are small and end by supplying the spinal nerve roots. Since the anterior spinal artery supplies anterior 2/3 of the cord, the occlusion of this artery will therefore result in a. Motor symptoms, due to involvement of corticospinal tracts and anterior gray columns, and b. bilateral loss of pain and temperature sensation due to ischemia of spinothalamic tract. Nb. The conscious proprioceptive sensations are preserved because the region of posterior white column is supplied by posterior spinal arteries. The segmental arteries are spinal branches of deep cervical, ascending cervical, posterior intercostal, lumbar and lateral sacral arteries. They reach the spinal cord, as the anterior and posterior radicular arteries along the corresponding roots of the spinal nerves respectively and nourish the nerve roots. There are about 8 anterior and 12 posterior radicular arteries which reach the spinal cord. After reaching the spinal cord, they reinforce the anterior and posterior spinal arteries to form 5 longitudinal arterial trunks. The radicular arteries are regular serial enforcements to the spinal arteries. The anterior radicular arteries are larger but less in number than the posterior radicular arteries. Frequently anterior arteries at the first T1 and 11th thoracic T11 segmental levels are very large and termed arteria radicularis magna, arteries of Adamkiewicz. Clinical correlation. The artery of T11 spinal segment is remarkably large and supplies several segments of the cord upwards and downwards. A fracture of vertebra involving this artery leads to softening of several segments of the cord. The artery at the level of T1 segment anastomoses with the other arteries in such a fashion, valvular fashion, that its supply is directed only downwards. Therefore, if this segmental artery is involved, the C8 segment is most affected. Nb. Radicular, segmental, arteries are more important in the vascular supply of the cord because they are end arteries and, therefore, if any one of them is blocked, the area supplied by that particular artery will be damaged. Venous drainage, Fig. 7.28. The veins draining the cord form 6 longitudinal venous, Fig. 7.28, channels around the cord, viz. 2 median longitudinal, one in the anterior median fissure and the other in the posteromedian. Sulcus. 2 anterolateral, one on either side, posterior to the anterior nerve root. 2 posterolateral, one on either side posterior to the posterior nerve root. These longitudinal venous channels communicate with the internal vertebral venous plexus and drained by veins which leave through the intervertebral foramina to empty into the vertebral, posterior intercostal, lumbar and lateral sacral veins. The internal vertebral venous plexus communicates above with the basilar venous plexus. Clinical problems. 1. Why are spinal cord injuries more common in the thoracic region of the vertebral column? 2. Explain why the herniation of intervertebral discs, also called disc prolapse or slip disc, occurs most commonly in the lower parts of the cervical and lumbar regions of vertebral column. 3. What are the types and effects of intervertebral disc herniation? 4. What is cervical spondylitis and its effects? 5. What is the anatomical basis of a tonic bladder or automatic reflex bladder or autonomous bladder in spinal cord injuries? 6. While performing lumbar puncture, why the lumbar puncture needle is most commonly inserted in the interspinous space between L3 and L4 vertebrae and the spine, vertebral column, is kept fully flexed. Clinical problem solving. 1. This is due to considerable displacement of the fractured segments of vertebra against the resistance provided by the rib cage, and also smaller diameter of the vertebral canal in the thoracic region. 2. The herniation of the intervertebral disc occurs most commonly in those areas of the vertebral column where a mobile part joins a relatively immobile part, viz. Lower parts of cervical and lumbar regions as they join with relatively fixed thoracic and sacral regions respectively. The discs commonly involved in the cervical region are those between the C5 and C6, and Co and C7 vertebrae. The discs commonly involved in the lumbar region are those between L3 and L4 vertebrae and between L4 and L5. 3. In herniation of the intervertebral disc, the posterior part of the annulus fibrosus ruptures and nucleus pulposus is pushed out like a paste coming out of a tube on pressure. The herniation may occur either in the midline, the central prolapse, leading to the compression of spinal cord, or posterolaterally close to the intervertebral foramen, the lateral prolapse, causing compression of roots of spinal nerves. 4. The cervical spondylitis is a degenerative condition characterized by a. Degeneration of the intervertebral discs, and b. The formation of osteophytes, spurs, from neurocentral joints of Luschka which project backwards into the intervertebral foramina, causing the narrowing of intervertebral foramina. Consequently, the nerve roots are compressed, leading to pain and muscle wasting along the distribution of the spinal nerves. 5. See page 245. 6. See page 52.